So, a brief introduction. What are patients' preference predictors based on new algorithmic tools? How they relate to respect for autonomy and to what is defined in biomedical ethics today as the substitute judgment standards. Then two sections on the relationship between preferences, their satisfaction and respect for autonomy. And then what perhaps is the most original part of the article, a critique of a prevalent line of thought that wishes to defend the position that we can respect the autonomy even of patients who are no longer autonomous. How? Because we can protect what they call the endorsed life view. And I disagree radically, so the paper is about that. If we have time, then a little bit of expansion on what is the positive conception of autonomy and informed consent, which to me we should defend, and finally the conclusions. So this is the meta claim about this presentation, but about the main point of the paper as well. It's a quote from Thomas Sowell: "There are no solutions, there are only trade-offs." And I think that when we talk about ethics and morality, most of the time this is absolutely correct. So today I'm not defending a solution to the many complex issues that we will see. I'm defending what I think is the best trade-off. And I critique others' proposals insofar as they are, to me, trade-offs that are not worthwhile to be defended. So let's begin with the introduction. So basically, the crucial problem for any model of clinical decision-making based on informed consent is that not all patients are sufficiently autonomous all the time. So patients may be temporarily incapacitated due to trauma or pathologies, or they may lack the capacity to make sufficiently informed decisions, such in the case of newborn or people with certain mental illnesses. In these cases, it may be challenging or impossible to ascertain which treatments these patients would prefer to receive or refuse. And when patients are not sufficiently autonomous to decide for themselves, others must decide on their behalf, assuming the role of what is called surrogate decision makers or surrogates. So depending on the clinical context, this role may be filled by a designated person, the caregiver, the patient's family or community, a person legally appointed by a judge, the clinician, or the healthcare team. However, the point is that surrogate decision-making is a common occurrence in the healthcare setting. So estimates suggest that up to 50% of older adults may lack the decision-making capacity at some point in their care. And nearly 70% of treatment decisions near the end of life are made by surrogates. So it's a huge problem. I have a brother working in intensive care, and they deal all the time with surrogate decision-making and all the problems coming with surrogate decision-making. And there are many, for it is notoriously problematic. First, surrogate may be unable to determine patients' preferences simply because they lack sufficient knowledge and information. Even relatives, life partner, and caregivers may be unaware of the patient's values and beliefs and thus be unable to decide which therapeutic path would best reflect their preferences and worldview. And moreover, surrogates may themselves have limited cognitive capacity, poor health literacy, or insufficient ethical preparedness. Another very significant problem, if you ask any healthcare provider, is that often they and the surrogates report and experience high level of distress when making substitute decisions. Well, of course, we have to decide over life and death issues for another person without having all the necessary information. So it's very stressful. The point is that in response to these challenges, scholars have proposed new technological solutions, including the development of decisional algorithms to reconstruct the preferences of incapacitated patients. So in 2014 was not the first, but one of the first papers. Reed and Wendler were among the first to advocate for a patient's preference predictor, a computerized tool that could infer a patient's treatment preferences by leveraging social demographic data. So the idea was based on empirical evidence showing that certain variables such as age, gender, income, and birthplace are statistically predictive of healthcare decisions on an aggregate level. In essence, individuals facing similar health decisions tend to select options that align with those chosen by others in similar demographic categories. So the proposal to develop a PPP, so a patient preference predictor, to supplement surrogate decision-making sparked an intense ethical debate, attracting two main criticisms. So, of course, the first one concerns the PPP predictive accuracy. Clearly, the case to build such a tool is stronger whether we can demonstrate that it is very accurate, at least as accurate as other surrogate decision makers, or perhaps even better than them, or even better than patients themselves. Reed and Wendler and colleagues cited a series of empirical studies suggesting that predictions based solely on demographic variables might be more accurate than those made by next of kin. And given that preliminary evidence, they argued that, yes, it was reasonable to develop such a tool, but more research was warranted. The second, of course, more substantive moral criticism is that the PPP was not respecting patients' autonomy because it was built solely on demographic variables. A PPP built solely on population-based data risks reducing a patient's moral agency to a set of demographic variables, potentially conflicting with the core principle of respecting patients' individual autonomy. But that is the past, 10 years ago, and we know there have been many revolutions in artificial intelligence and models, and so we arrive at the end of last year with this brand new proposal by Hirth and colleagues. Because to address those two limitations, accuracy of those kind of models and potential risks for the respect of patients' autonomy, they propose to develop a brand new sort of model, a personalized patient preference predictors. So, unlike the PPP, a P4 leverages recent advancement in machine learning and generative AI to extract patients' individual preferences, even those that might be implicit. How so? Well, the proposal is very theoretical, but the basic idea is the following one. A P4 will be built using a person-specific corpus of text, which could include emails, social media posts, blog posts, digital health records, and other online activities. This text would then be used to train a personalized large language model. What's the end result of this endeavor? It's the following one. The result would be a kind of digital psychological twin of the person that could be queried in real time as to the patient's most likely preferences for treatment in any given healthcare crisis. In short, the P4 would be a personalized rather than population-based patient preference predictor. So, just to be clear, we have a situation in which patients cannot longer decide for themselves. There is this tool built using their individualized personal text. Then if I am an healthcare provider, could inquire and simply ask it what the patient would prefer. And allegedly, that would answer giving the same preferences that the patients would have given if competent. Now, that's the article. A personalized patient preference predictor for substitute judgments in healthcare. Technically feasible, according to them, and ethically desirable. And that's the main point of the article. And I'll draw the attention, I know Brian Firth is a fantastic bioethicist, but also to other authors, so Julian Savulescu, David Wender, Annette Reed, Dominic Wilkinson, so many others. These are the gotha, to some extent, of contemporary medical ethics. And I underscore that because I think it's really important to acknowledge that this proposal is built upon an entire line of papers, arguments, philosophical positions that were produced in the last 10 years by this group of well-known bioethicists. So, as I said, now we come to point number 2, autonomy, surrogate decision-making, and substitute judgment. So respect for autonomy has consistently been at the forefront of the ethical discussion surrounding the proposal to develop this kind of tool, the personalized or patient's preference predictors. Even Wendler, for example, and Reed, in many other papers, they devoted maybe 2 papers just to answer autonomy-based objections to the initial proposal to develop a patient's preference predictor. So autonomy has always been really the focus from a moral standpoint. And more specifically, Irk and colleagues argued that a P4 would allow to respect the autonomy of incapacitated patients better than the PPP, so of a patient's preference predictor not personalized. And even better than human surrogates, as it would allow for a more accurate form of substitute judgment. And now we have to be really specific in medical ethics about what we are talking about. And what we are talking about is called the substitute judgment standard. So the substitute judgment standard, SJS, differ from other decisional standards for surrogate decision-making, such as the best interest or the rational person standard, for it instructs the surrogate to make the decision the incompetent person would have made if competent, thereby relying on a hypothetical form of consent. So basically, to be clear, we have a patient that is no longer autonomous, and we have to decide on her or his behalf. Now, we can adopt different standards. We can decide what is in her or his best interest. We could decide as a rational person would decide, whatever that means, or we could decide using this specific standard, the substitute judgment one, meaning that we want to choose what she or he would choose if still competent. But now there is a fundamental question, which is the following one. Yes, the SJS introduces a few theoretical challenges. The first one is this very simple question. How can a P4 empowered substitute judgment respect the autonomy of incapacitated patients if these patients are no longer autonomous? Seems very naive. To me, is at the very core of the argument. And I repeat just to stress how important it is. So we have persons who are no longer autonomous, and we are said that there is a way to respect their autonomy, even though they have not expressed anything in advance. We are not talking about advanced directives. We are talking about reconstructing post hoc their preferences and claiming that by satisfying those preferences, we would thereby respect their autonomy using the SJ standard. Now, how is it possible to answer this question? Well, in the paper, which is critical, they answer in the following way. They say that one way of respecting a person's autonomy in making a substitute judgment is simply to get the right answer. That is, to choose what they would choose in the current situation. So, to get the treatment right, if the person would have wanted to be unplugged, for example, if we unplug the person, we get the choice right and we respect the autonomy of that particular patient. Now, this view aligns with other proposals They are very influential in the debate. This one was by Camillo Lamanna and Lawrence Byrne. Should artificial intelligence augment medical decision-making? The case for an autonomy algorithm. They claim that this could be useful even for autonomous patients to sort of decide in a more empowered way, which could be. But they also claim that this algorithm can be used again for patients who are no longer autonomous. And they explicitly define it as the autonomy algorithm. And I'm not really convinced that's right. And in order not to attack anyone, because papers are very complex, it's always very difficult to reconstruct the premises. In this paper, I decided to formalize this very simple argument, which I believe is really beneath the discussion. And then I focus on it rather than on specific textual passages from others' paper. So the argument is as follows, I believe. They claim that substitute judgment allows to respect the autonomy of incapacitated patients. Respecting autonomy entails choosing what incapacitated patients would choose to get the answer right. Choosing what patients would choose requires identifying their treatment preferences. The P4 enables the identification of patients' treatment preferences. Therefore, using the P4 allows to respect the autonomy of incapacitated patients. Now, most of the discussion, most of the commentaries, that article was the most read article in the American Journal of Bioethics for many months. It was very influential. It attracted a lot of commentaries, proposals, and critiques. But most of the critiques were directed at the premise number 4. So the actual ability of those kind of models right now to be technically feasible and be very accurate. But as I said, I'm more of a moral philosopher and bioethicist. So instead, I guess we should critique in a complementary way premise number 1 and premise number 2. This is what I'm going to do. So in my view, the view that respect for autonomy can be equated with the satisfaction of individual treatment preferences is very questionable, whether such preferences are not actual, explicit, and specific. And second, that incapacitated patients have a residual autonomy to be respected is not self-evident and requires further justification, which in my opinion, nobody has ever provided, as I will now proceed to argue. So point number 3, in order to get a sense and to deconstruct the overall argument, let's begin with the simplest point, which is to say to argue about the link between preferences, specifically presumed preferences, and respect for autonomy. So now I clarify what you can see in the slide. So at the outset, it is important to clarify why getting patients' presumed preferences right is often insufficient to respect their autonomy. So consider the case of an autonomous patient who expresses the preferences to receive certain treatment, like X. If the doctor administers treatment X, she will then satisfy the patient's preferences and respect her autonomy. But conversely, consider the case of a doctor who decides, without informing the patient, to administer treatment Y instead, because she thinks that it would be more beneficial and cost-effective, despite patient's explicit request or consent to receive X. But in this case, the doctor has not only failed to satisfy patient preferences, but also disrespected her autonomy. I wanted and consented to X, and you gave me Y. So in both examples, it is therefore true that respecting patients' autonomy entails respecting their explicit treatment preferences. So to some extent, it is right. However, consider this other case of a patient who suffer from a vague sense of uneasiness and undefined fluctuating symptoms. The doctor is aware that, based on recent evidence, a placebo pill could aid in alleviating these symptoms. She then decides to deceptively prescribe a placebo, believing that one would the deceptively prescribe would the patient be aware that the placebo could help, she will consent to its use. And two, a placebo is only effective if administered deceptively, and thus deception is the only option to elicit the desired beneficial effect, which is not true because I work very much in the ethics of placebo effect, and but for the sake of the argument, just assume that it is so. So you require deception for the placebo to be effective. Now, in this case, it is clear that if you administer a placebo deceptively, you are not respecting patient's autonomy. This is a basic fact in medical ethics, and I guess we don't have to argue for it. But the interesting case is, suppose that one is true. So the doctor is right, and the patients really would prefer a deceptive placebo in this situation rather than no prescription. Receiving the placebo would then satisfy patients' presumed preferences, even though it would disrespect their autonomy. Thus, it is not always true that one way of respecting a person's autonomy is to choose what they would choose in the current situation. One can consistently choose what another person would presumably choose and still fail to respect their autonomy. So I guess that this example is very simple, but it shows one important thing, namely that in discussing the ethics of satisfying patients' treatment preferences, two distinctions are key. One is between revealed or explicit and explicit preferences, or presumed, so presumed versus revealed. Presumed preferences when one's implicit preferences are inferred by surrogates, for example, or a computer-based tool like the P4. And the second distinction is between two logically independent goals. One is respecting autonomy, and the other is satisfying patients' revealed preferences, as with informed consent, for example. So this conclusion extends to substitute judgment via P4. Even granting that the P4 could be accurate in predicting patients' individual presumed treatment preferences, from this fact alone, it does not follow that satisfying such preferences would also respect their autonomy. So that's the first point. But you may say, well, of course, but the P4 is actually using a lot of data. People are leaving behind a trail of digital records and of their preferences as well. And that's why the P4 is so powerful. It's not just presumed preferences. In most of the cases, the P4 would find some very close scenario that the patient has previously confronted or even revealed explicit preferences. And in that case, it's a different story. The P4 will be using revealed past preferences and simply generalize them to the current scenario. This prediction would be based on explicit and revealed preferences rather than on presumed or implicit ones. However, my point is that even acting on a patient's past revealed preferences, so explicit but in the past, and not related to the decision that we are confronting right now, that may still fall short of respecting their autonomy in any significant sense. So consider again the case of the deceptive placebo. Now, imagine that patients had previously expressed their opinion about a similar situation on a social media while commenting on a medical journal, stating that if I were in the same situation, I would prefer to receive the deceptive placebo. Now, if the doctor were aware of this post, would administering the placebo be a way of respecting her autonomy, simply because we are basing our current decision on those past revealed preferences? Well, I argue that absolutely no. Absolutely no. Administering the deceptive placebo would still constitute an act of medical paternalism. And while this paternalism may seem more justifiable given the patient's previously expressed preferences, it remains paternalistic nonetheless. This is because Respecting autonomy typically requires more than merely knowing and acting on previously expressed treatment preferences. It demands an explicit, first-person, actual, and specific consent. And there are different reasons why we want it to be exactly that way, and conversely, why we came up with the current framework that we have about informed consent, what it means to be autonomous, what it means and why it is important to respect autonomy. So there are several rationales, three in particular, why we want it to be that way, and I argue for it to remain that way. One is well-documented unreliability of previously expressed preferences. So this stems from the inherent difficulty humans face in accurately predicting future states of mind, particularly when their health or circumstances change significantly. So there are many research in decision-making and in psychology that has shown decisively that individuals frequently misjudge their future feelings, preferences, and adaptive capacities. So one thing is to express your opinion in front of a medical drama. Another is to be in a clinical context and to decide for yourself. They might seem similar, they're not. They're very different experience. As such, caution is warranted when interpreting previously revealed preferences as reliable. But this concern becomes especially pronounced when relying on data from like social media or casual communications, where expressed preferences may not reflect deeply held beliefs and values. So, for example, someone might declare on social media that they would rather be dead than live with a significant spinal cord injury. And yet many individuals who later experience such disabilities, report a quality of life far exceeding their previously expectations, and often choose to live rather than to pursue assisted suicide. The second reason, as you can see, is that second rationale to grant autonomy in acts of consent is that patients, prior to becoming incapacitated, may have lived a life they never truly endorsed. So the model would extract from your preferences, but maybe you could never express your own feelings or ideas or true values because of many reasons. And that's why we want to protect actual consent, not just presumed consent or revealed based on your past behavior. And in absence of this element, it becomes unclear how the respect of one's revealed preferences alone qualifies as respecting their autonomy. So, since my time is almost up, I come just to the gist of the most original part of my presentation, and then I will conclude. If you're interested, you can read the rest in the paper. That's perfectly fine, and I remain available. So the point is, okay, if by satisfying neither presumed preferences nor revealed past preferences, we have a guarantee that by using a P4 we respect someone's autonomy. What does it mean to respect the autonomy using that standard that we introduced before? And well, what is the added value that we have in reconstructing post hoc the preferences of patients? Well, now it depends on which notion of autonomy you take as your basis. In the paper, I take the one proposed by Beauchamp and Childress. There are many more, but this one, I guess, provides a fairly shared common ground. It is based on the distinction and conjunction, rather the distinction between agency and liberty, the capacity for competent and intentional action, and independence from controlling influence. Now, even the critique of other rationales agree that it does not make sense to talk about liberty of incapacitated patients because they are no longer autonomous. They cannot be constrained in their liberty since they have no liberty. It makes no sense to be talking about respecting their liberty. Therefore, if we are claiming that a tool like a P4 can respect in some way their autonomy, we have to argue that it does so because it somehow allows us to protect and respect the other parts, not liberty, but agency. And in fact, Philip and Wendler articulated that in what they call the endorsed life view, which basically instruct clinicians and surrogates to make treatment decisions that promote the life patients valued in the past for themselves. Others can still make treatment decisions for them that promote the life they endorse for themselves. Thus, while respect for liberty does not apply to incompetent adults, respect for their autonomy in this sense does. So we can protect their view of life they endorse while they were autonomous. So the key argument they use is that it's not possible to respect the liberty of incapacitated individuals, but we can still respect their autonomy by ensuring that the course of their lives going forward aligns with their values and beliefs about how their life should proceed. This can be really applied to it before. Obviously, we can extract preferences and we can infer a lot about people and also carry on what they valued in their life previously and prior to becoming incapacitated. Now, my critique, and we conclude with these points, a couple more slides, but I'm nearly finished, is that this proposal would be compelling only if applied to patients who have previously completed an advanced directive, which is not really controversial at all, not even for me. That's an actual specific decision made now in prevision of future inability to decide for yourself. So it's not controversial, perfectly makes sense. We are protecting by carry on the wheels in this advanced directive precisely what they valued in their life, they endorse their life. Okay. However, the argument is much less persuasive for patients who have left no ADs or clearly and publicly recorded treatment indications. They have said nothing about the potential use of tools like the before or the autonomy algorithm. Instead, in the paper, they seem to suggest that we should use them even if no one expressed either a consent or a refusal of them. But the point is important is this one. So the endorsed review seems to suggest that the respect of their agency goes beyond the fostering of their actual autonomous decisions and translates into a positive moral obligation to actively carry on patients' endorsed life plan, even though they have said nothing about that. But the problem is that if such an expanded view of agency is right, then it would extend to all decisional contexts, not just for incompetent patients. If it is morally significant to ensure that the life trajectories of individuals reflect their endorsed views on how their life should go, even with no actual decisions, this principle should apply to all agents, including those who are still competent. So it cannot be an intermittent kind of autonomy. Either this form of weak autonomy is always worthy of respect, or it is not. It does not exist. If, however, weak autonomy is always worthy of respect, then a physician in the context of the deceptive placebo example of before could be said to be respecting the weak autonomy of a patient to whom she has deliberately lied. To respect this kind of autonomy, it would only be necessary for the physician to ensure that the course of the patient's life going forward is consistent with their values and beliefs regarding how their life should proceed. So instead of a straightforward case of medical paternalism, which is the bedrock of what we now understand with the term medical paternalism, this would then be framed as a matter of balancing respect for weak and strong autonomy. It's a different trade-off, and one that I argue we should not be making, because it blurs very critical, basic, important moral distinctions. I conclude with this one. There are two ways out of it, of this. Either you provide a different account of the kind of autonomy protected by the kind of standard they wanted to advocate, this substitute judgment standard, and I would like to say good luck. I've read many papers about that. No one has, to my knowledge, succeeded in proposing something of that sort. But the reason to me is fairly apparent. We have constructed respect for autonomy, and all those concepts in some consent, they are not perfect, of course, but to protect certain kinds of rights and to protect people in certain kinds of situations. This is like stretching this concept way too much, and you actually risk of breaking them and making them no longer useful for what they were meant for. Or we can fall back on a narrower conception of autonomy, one that is anchored to an actual, local, first-person voluntary decisions, thus renouncing the view that the substitute judgment standard is primarily a standard justified by the respect of patients' post-autonomy. So now really the conclusion, that was the part to be made quick, but just to say why it is so appealing, this perspective. Because we have a strong moral intuition that to get the preference right, it's important. But it's important, like it is important in a funeral to play the song that the deceased person would have wanted to be played. Yes, it's important. We feel it's an important thing to select the precise song that person would have wanted. But this has nothing to do with the respect of the person's autonomy. We are simply making like a sign of respect. We are acknowledging a past identity. There are many other moral goals that we want to pursue and for which we can make sense of the same moral intuition that have nothing to do with respect for autonomy. And so, just a conclusion. Respect for autonomy cannot be reduced to ensuring that the right treatments are provided. Extending the normative relevance of agency beyond actual first-person decisions blurs important moral distinctions over cases of medical paternalism. And while the use of P4 for substitute judgment may not succeed in respecting the autonomy of incapacitated patients, this does not mean that the development of such tools lacks moral or practical significance. We can develop them for many other goals, including easing healthcare professionals' decisional burden. Worthwhile goal, it can be argued, it can be defended. We will see if they are technically feasible, but this has nothing to do with the respect of autonomy. And that's why the paper is called Realigning the Ethical Debate, because today we are debating things that, in my opinion, we should not be debating, and we should instead focus on other kinds of goals. Thank you very much for your attention.
Thank you very much. So we have about 20 minutes for questions or comments or discussion. Anybody also online wants to start it off?
Thanksgiving started, so.
Yes.
But just be careful with this campaign.
Yes.
Well, okay.
It will go down slowly.
They will, yeah.
Okay.
Maybe I can pull it up. So I have a. So I like the style of the paper, but even if I might disagree with some of the some parts of the argument. So first, I wanted to thank you because I mean this shows that there is a lot of work that has been done in bioethics to define terms that everybody is using now, and there is probably a deep need to go back to some of these foundational work in bioethics to advance also in relation to novel challenges. So you seem to have two arguments. Now, one is that respecting preferences doesn't entail respecting autonomy, and you show that the two things can fail to overlap. And the other part of the argument is that we don't really need to care about autonomy for incapacitated patients. I mean, I'm putting it simply, but now the first part of the argument, it seems to me, so my line of criticism there would be, yes, okay, there are circumstances in which by respecting preferences, you are failing to respect autonomy. And you made the case of deception. No? And I was wondering whether this is true only if deception is in the mix. So when there is no deceptional element in the way in which we try to satisfy people's preferences, maybe you're not violating. There is no other way to violate autonomy. I mean, and so I was wondering if you have thought of any other examples in which, in the absence of deception, you can still argue that respecting preferences can go straight in the face of autonomy. And the second point is about the need to respect autonomy with respect to incapacitated patients, would you then say that there are other standards that are more plausible, like, for example, back again, the best interest standard? So I leave it there. I might have other comments.
Well, thank you. Very good questions. So I see a toy in front of you, which is an unresolvable puzzle, by the way.
For the time being.
For the time being. But also it reminds me that obviously you are a parent. So concerning the first point, I guess, yes. So for example, you can decide instead of another person, as if the person would have, you assume, chosen in that scenario, without informing them. No deception, still paternalistic. Maybe you do it all the time for children, it's perfectly justifiable. But I think that one of the points of the paper is also to make it clear that there is a sort of slippery slope in which the more we relax those kind of boundaries, the more we allow other person to simply say, we are respecting the autonomy of that person just because I presume that she would like so and so, which to me is very questionable. And the burden of proof to show that this is really connected to autonomy falls on those arguing this heterodoxical view, in my opinion, and they're so far failed to do so. Coming to the second point,
whether there is whether the best interest.
Very good question. I believe so. I believe so, and I believe that we need to reflect way more on those standards. Those standards are a particular case of bioethical scholarship right now, meaning that very few minds are reflecting on fundamental issues. Lots of minds are reading the initial paragraph in bioethics manual in which those standards are summarized, assuming that the foundational work has been already done. But then, where? By whom? And when do we agree that this is the only way in which we have to deal with those kind of issues? And in fact, they are all very problematic. The substitute judgment standard is very problematic. The rational person standard is very problematic. And I would say that, in my opinion, the expansion of the best interest standard probably would make a lot of sense in those situations. Like in the funeral, we want simply to pursue the best interest of the person broadly construed. What are the interests? They might include protecting their values, the ones that they endorsed during their life, which is basically the basic moral intuition justifying the construction of the endorsed life view, which to me you can subsume entirely into a more expanded version of the best interest standard, but with one which is different by the standard one. So there has been a lot of, well, not a lot, but a bit of debate about that. But of course now bioethics literature is huge, so I'm sure you can find tons of paper that I have overlooked about that. But I think that you're right. That's a very interesting decision, and there is a lot of work to be done on things that might seem like they are just theoretical, but they're very practical. Because otherwise, if you don't have clear ideas about the moral foundations, then you find yourself arguing for new tools that are the hot deal right now in the discussion, but without knowing exactly what you're doing. Thank you.
Marco, I really enjoyed your paper. I have my own problems with the argument that was made on the preview on the paper. Also, I commented. And I'm just actually reflecting in what you just said about how the scholarship in bioethics is evolving or has evolved. I'm feeling this strong this effort to fit take whatever we call autonomy, which we agree is a good thing. We need to respect it and fit circumstances, technology, developments into that. Because once we call it respect of autonomy, it's going to work for us.
That's perfect. I agree.
And I think, well, for reasons that we don't have to explain here, this is very problematic. One of the problems I think it creates is that it puts us on this kind of like one-way street, right? Let's just fit into autonomy, whatever is out there, the messiness of life, the developments of different technologies, all this kind of stuff. which I think reduces the type of scholarship we are producing, but also maybe it does the other thing. And I think this is what I always had some issues with Annette Ritz and Wendler's paper from back in the days that we were thinking AI and high tech. We're just thinking like, okay, just put people in boxes. And that approach, I think, I'm concerned when bioethics endorses this approach, because it tries to quantify or make things that you could tick that box and you're morally okay, by reducing the complexity of moral interest that you have in a constellation of somebody who is incapable of making a decision, because ignoring, the other members of that constellation, because you have well, we legally call surrogates, but there are proxies with their emotions, with circumstances, etc. So we take all that and we make a very almost quick equation to solve it. And I think that also takes away the effort that needs to be made. And granted, we don't have the time, we don't, make mistakes and all of that, but it takes away that effort that should have been given in figuring out the specifics per case by clicking the box. And I think this reduction for me is problematic, and I think our field starts endorsing that.
I perfectly agree.
I would be okay with doing it as long as we are honest about what we're doing.
Yeah.
So instead of calling it autonomous reservation, then look, people, it's a very complex world. We don't have enough resources, time, effort, etc. We need to make quick decisions. We will try to figure it out this way. And let's all agree that the circumstances and constraints of life, that's honest.
Yeah.
As opposed to I feel a little bit, and I'm reading this kind of papers and I'm thinking like, we're pretending, is that a genuine moral interest here?
Yeah.
Or are we pretending we are doing the right thing?
I perfectly agree. Thank you very much for this comment, because I share the same view about what is happening about those topics. It's like certain keywords are like a J3 card right now to argue whatever.
No.
And I would say probably that I'm more attracted right now to a deflationist perspective on many bioethical debates. To just make an example of something that I think is really close to what you just said, we have seen in the past a great expansion with respect to clinical trial, with the concept of the extension of autonomy for children participating in clinical trial, with the concept of assent, for example, which is very confusing. I'm not claiming that it's not important to respect, obviously, preferences of patients. But again, we have a concept of autonomy which we define in certain ways. And then in those debates, again, it became enlarged to create other constructs that are loose proxy to things that we might conceptualize in other ways, and probably be more honest about that. But I share the point with you. It's also a way of simplifying the moral landscapes of clinical decision making by just seeing certain elements while disregarding others. I share your fear that it's not very productive, but probably we don't even need that. So we can be honest about it. We can take home the proposal to develop this kind of tools. We just have to be very clear about the scope.
Because I don't object to the idea of developing the tool. I think actually it could be very useful in many contexts, not in incapacitated patients, but also, in all kinds of in other contexts. So, but my objection is what these tools are allegedly do compared to what these tools can do or ought to be doing.
Yeah.
And so this is where I find I find it problematic as how the field is moving forward in endorsing that language, and that kind of reduction is what I would say.
Yeah.
So I mean, in general, that's I think a good example and and I think you've analyzed really well, but I think it's not just this example.
There are many more, and I think that what is really interesting is that you can, if you notice that, you will spot it in the paper. So there are argumentative passages that don't hold up. So, and also you see in that paper, there is the section about autonomy. Initially, I thought about criticizing it more directly, but then I decided to focus on the more abstract underlying arguments because the section is itself cannot be criticized. It's a patchwork of different arguments. It's really hard to follow, but that reflects to me the fact that yes, you can try to go along that line and reduce everything and see everything from the point of view of autonomy. But it's also very difficult to argue. You have to be a little bit confused, but then they are very good writers. So once you read the first time, it makes sense. But then you start thinking and making less sense every time you read it another time.
Comments? I also just want, it came to my mind right now that, I mean, for a long time in the past, I would say in between, I don't know, 2005, 2015, there's been a very strong critical approach to the notion of autonomy in bioethics that was considered to be way too much of a narrow angle to, for example, in clinical research ethics or in research ethics in general. And it was substituted by this participatory drive for a long time in bioethics. And this is probably, it's sort of ironic that now it goes back at the center of this, as the pivotal notion. I was just wondering how much, so you did a lot of work also on living will, and I was wondering how much the objection that we can change opinion throughout life, and so that also all the standards, including the endorsed life view standard, are at fault of recognizing that we can change. Like, how much do you think this extends to the living will? Because you seem to have a pretty strong opinion about the living will being a good way to preserve autonomy. I was wondering if it's always possible for autonomous decision makers to change their mind about their preferences. How much do you think that your critique also fires back against living will?
Well, let me say that I probably help like 4 to 5 people each week to compile an advanced directive. So I have like first-hand experience with that. And although I think it's a very good tool for those who are absolutely convinced about what their value is and what they want to avoid if they become incapacitated, it's full of problems as well. So probably an advanced directives, as it has been proposed, empowered by this sort of algorithmic tool, could also be a way of bridging the gap between your current preferences and also the multiplicity of clinical situations that might ensue, and even the advancement of technologies. It's really difficult to predict. So usually when I hate people in filling their advanced directives, I advise them to do 2 things. One is to keep it simple, just the main ideas about what you absolutely want to avoid, mainly to be plugged in with life support if you are deemed unable to recover your consciousness. That's the most important thing. And the second is to find a person that you trust, that you nominate, that could decide in your staff, basically. And I guess maybe a P4 could be useful to bridge that gap, because you always need somebody able to cope with the current particularities and situations. So just to answer, yes, it's full of problems. Traditional living wills are full of problems. Yes, I'm mildly optimistic that this kind of tools can aid to address some of the limitations, but that's it.
But you would go straight to the end of the argument that if you are incapacitated, it's no longer about autonomy at all anyway.
Oh, you made an autonomous decision, and then we respect if you made a living will. we respect, and that is respect for autonomy, because you made a specific actual decision saying if that happen, a conditional decision, then I want that to happen to myself. It's only that the time is way bigger than normally in standard
Yeah, in
situation.
that case, though, you might be respecting the autonomy, but you don't have any way to know if that their actual preference in that very moment would have changed.
Yeah, that's right. That's right, and you should inform the person compiling the legal will that it could be so.
Yeah.
Then it's up to them, and their autonomy is the decision to file it. But also, that's a good thing in a sense, because it it put the responsibility on the person willing to write down the advanced directive, and many people don't, because they don't want to risk it. Just like that. So sometimes it's very difficult to decide, and it takes risks. So
The risk that you might have changed your mind, and in fact, what is written there is no longer your preference.
exactly. But if you know and you still go on, you take the risk on. That's actually taking. So autonomy is also coming with sort of responsibility for what you decide, taking risk. So that's normal in my opinion, although not perfect.
Okay, so reached top of the hour, so conclude here. Thank you.